So now we'll see the familial colorectal cancer. Familial adenomatous polyposis. So familial adenomatous polyposis contains 1% of all colorectal cancer incidents. Hallmark feature include hundreds of thousands of colonic polyps that develop in a patients with their teens to 30s, and if the colon is not surgically removed, 100% of the patients progress to colorectal cancer. And extracolonic manifestations include benign conditions like congenital hypertrophic of the retinal pigment epithelium, mandibular osteoma, supernumerary teeth, epidermal cyst, adrenal cortical adenomas, desmoid tumor. Although these tumors may lead to obstruction, and malignant conditions like thyroid cancer, gastric small intestinal polyps seen in 5 to 10% of the duodenal or ampullary adenomas, and brain tumors. Brain tumors may be of two types, glioblastoma multiforme or medulloblastoma. And particular association of the brain tumors and colonic polyposis is called Turcot syndrome. So this is important. And the colonic polyposis in Turcot syndromes are fewer and larger than the classic FAP. Then third variant is attenuated form of FAP, which harbor up to 100 colonic polyps and has predisposition to colorectal cancer in patients when they are in their 50s and 60s, so late occurrence. FAP is an autosomal dominant disorder with nearly 100% penetrance. However, 30% of the patients de novo mutations and are with an family history. And based on the karyotype analysis that reveals an interstitial deletion on human chromosome 5q and subsequent genetic linkage analysis to 5q21, the gene responsible for FAP was identified as APC, and these patients with FAP inherited a mutated copy of the APC gene, thereby predisposing them to early onset polyposis. And during life, patients with FAP requires inactivation of the remaining APC gene copy, which accelerates the progression to colorectal cancer. Interesting genotype phenotype association exists between location of the APC gene and mutation and certain clinical manifestations such as congenital hypertrophy of the retinal pigment epithelium, desmoid tumors, and classic FAP versus attenuated FAP. The APC gene comprised 15 exons and encode a protein, nearly 2,850 amino acids, and nearly all germline mutations in the APC gene lead to truncated protein, which can be detected through molecular diagnosis assay that can be inherited into genetic counseling and genetic testing of affected patients and at-risk family members. Function of APC protein and the interrelated pathway and regulatory molecules will be discussed later. Now, HNPCC accounts for 3% of all colorectal cancer. Salient features include up to 100 colonic polyps, hence term non-polyposis, preferentially albeit not exclusively in the right or proximal colon, and there is an accelerated rate of progression to colorectal in this diminutive. At times flat polyps with a mean age of onset is around 43 years, and this is designated as HNPCC type 1. Flat polyp being at the age of 43 years, type 1. And type 2 HNPCC is distinguished by extracolonic tumors that originate in the stomach, small bowel, bile duct, renal pelvis, ureter, bladder, uterus, ovary, skin, and perhaps the pancreas. The lifetime risk of colorectal cancer in HNPCC is 80%, and up to 50 to 60% of the endometrial cancer, 1 to 13% of all other cancers. And of note, variant of HNPCC involves kill tumors that is designated as Muir-Torre syndrome with skin tumors, and HNPCC is defined as classically by the modified Amsterdam criteria. So Amsterdam criteria, at least 3 relatives with the HNPCC associated cancer like colon, colorectal, endometrial, small bowel, ureter, or renal pelvis. At least 2 successive generations should be affected. At least 1 case before the age of 50, FAP excluded, and tumors should be verified histopathologically. So this criteria is to identify individuals at risk for mismatch repair deficiency, that is MSI high. So there are Amsterdam criteria, at least 3 relatives with HNPCC associated cancer, 2 successive generation, 1 case before the age of 50, FAP excluded, and tumor should be verified histopathologically. HNPCC is an autosomal dominant disorder. 80% of the penetrance, genetic and biochemical approaches lead to discovery of the involvement of the human mismatch repair gene in HNPCC and recognized as the human orthologs of mismatch repair genes encode described in the bacteria and yeast. Human mismatch repair genes encode enzymes that repair error in the DNA replication, and that may occur in spontaneously or in exposure to exogenous agents like ultraviolet light and chemical carcinogens. And mutation in one of these mismatch repair genes result in MSI microsatellite instability, and which creates a milieu of somatic mutation of the target genes like TGF beta 2 receptor, BAX, IGF type 1 receptor, and among others, HNPCC associated tumors. About 60% of the germline mutation in HNPCC they are found in either MLH1 or MSH2, but mutations in other members of family like MSH6, PMS1 and PMS2 they are rare, thereby indicating that other genes are involved but yet to be discovered. Genetic testing is not facile for HNPCC as it is for FAP, but it involves sequencing of both MLH1 and MSH2, and if a germline mutation is found, then the remaining at-risk family members that can be genetically screened. MSI testing, MLH1, MSH2, IHC, that can be performed on tumor specimen as a possible prelude to genetic testing. While this preliminary screening tests have traditionally only been implicated in patients who meet the Amsterdam or Bethesda criteria for high-risk family members, there has been a strong push recently towards expanding this testing to all cases of colorectal cancer. The proponents of this universal screening approach argue that HNPCC is underdiagnosed, with a significant number of cases being missed by selective testing. Numerous questions remain, however, as to logistics, infrastructure, and expense of implementing such an ambiguous changes. Then there is one hematomatous polyposis syndrome. They are rare syndrome and mostly affecting the pediatric and adolescent population. Represents 1% of the colorectal cancer annually. And the Peutz-Jeghers syndrome. The first is Peutz-Jeghers syndrome, which involves large few colonic and small bowel polyps that can manifest as GI bleed or obstruction and increase risk of colorectal cancer. Polyps are distinguished by smooth muscle band in the submucosa. And hallmarks are clinical features. Physical examination includes freckles on the hands, around lips, and in the submucosa periorbitally. Associated changes include sinus, bronchial, bladder polyps, and 5 to 10% of the patients have sex cord tumors. Patient also develop lung and pancreatic adenocarcinoma. Gene responsible is LKB11, a serine threonine kinase STK. Juvenile polyposis, that is overlapping clinical manifestation with Peutz-Jeghers, but polyps tend to be confined to the colon. In case of the gastric and small polyp described, there is an increased risk of colorectal cancer. Extracolonic manifestations are not prevalent in case of juvenile polyposis, and this is a polygenic disease involving the germline mutations of P10, SMAD4, BMPR1 or other gene yet to be identified. Cowden is a hematomatous polyps anywhere in the GI tract. Surprisingly, there is not increased risk of colorectal cancer. About 10% of the patients have thyroid tumors and 50% have breast tumors. And germline P10 mutation have been reported. And it is estimated that 20 to 30% of the colorectal cancer are compatible with the inherited predisposition. Independent of known syndrome, identification of other responsible genes will have a great clinical impact. Intensive approaches are being pursued through sibling pair studies and the family studies. As previously mentioned, patients may be predisposed to an increased risk of adenomatous polyps as well in the context of family history of sporadic adenomatous polyposis. Thank you.